Hi, this is Tom Inge, giving you one last screencast from Cincinnati, Ohio. Hope you guys are having a wonderful meeting there in Chihuahua, Mexico. This one is a hot topic in bariatric research. I wanted to talk to you a little bit about alcohol addictions and suicide, what we know from the adult literature, and what we're finding out slowly from the teenagers. There are emerging reports of patients who develop drinking problems and sometimes other addictive behaviors after bariatric surgery. These include things like alcohol misuse, compulsive shopping or buying, gambling, high-risk sexual behaviors, as well as compulsive exercise, if you can believe that. Let's talk about alcohol for a minute. That's one of the more common problems that we think about outside of the bariatric world as well as inside of it. And when it comes to adolescents, we really know very little right now. I'm going to talk to you a little bit about that in a minute, but to start off, in the adult arena, even here sample sizes are usually small and there's not much in the way of data to look at. The definitions are also often inconsistent, which makes it hard to make assumptions or interpretations of the data. We'll look at some of the larger studies and talk about possible mechanisms. When you're talking about alcohol, it's important to discriminate between a lifelong behaviors as well as current behavior. So somebody might have a long history of alcoholism many years ago that's no longer been active, over the past year or so. So in structured clinical interviews, a number of investigators here are showing us that the incidence varies from 1% with alcohol abuse or dependence all the way up to 33%. Now, some of these responses that you get when you're actually collecting this kind of data from interviews might have to do with how independent the interviewer is from the bariatric program. And so those that are very independent of the bariatric program, where they really know that they're not talking to the surgical group, may tend to give you more honest answers and higher scores. So up to 33%, though, Jim Mitchell here has found will report alcohol use or dependence. Now, in terms of current use, most of the people that are about to undergo surgery should not be using alcohol. And so, in fact, they do not report that they're using alcohol, as seen here in these numbers at the bottom. Less than 1% typically are using alcohol, or at least reporting that they're using alcohol. So other than this structured clinical interview to gather this kind of data, there's also a paper and pencil measure called the Alcohol Use Disorder Identification Test. Now, this is a pretty commonly used instrument in the industry, that is by researchers who want to look at alcohol use in a variety of populations, but in this case bariatric patients. So this instrument has three major ways that it's scored, looking at dependent symptoms, alcohol-related harm, not being able to remember, hurting somebody, hurting yourself, and then in a total score. And this is the instrument that we use in teen labs. It's also the instrument that Wendy King and colleagues used in the adult labs and published their data in JAMA 3 years ago. And let's look at their data, because it is kind of interesting when it comes to the gastric bypass. These are the gastric bypass data with 1,356 adults who completed the instrument. What they found is that alcohol-related harm increased from 6% to about 10%, and that was significant. Alcohol-dependent symptoms increased from 2.5% to 6%. And then the overall audit score greater than 8, that is a concerning number of items that they scored positive on, went from 2.4 to 6.4. Again, significant at year 2. So in gastric bypass in adults, it seems as though there is a signal for increased alcohol use in the LABS study, which is a U.S. multi-center prospective study. In that same study, they had almost 500 patients who underwent gastric banding. And when the alcohol use disorder inventory was administered to these individuals, they really saw no increase in any of the domains, from alcohol harm, alcohol dependent symptoms, or the audit score greater than 8. So again, to summarize, it looked as though there was a signal for increasing alcohol concerns and use in the gastric bypass patients, but not in the gastric band patients, according to this data from labs. Let's go across the pond to Sweden and look at the Swedish obese subjects study. This is probably the largest and longest going study, over 2 decades now, of studying these Swedes who underwent either a gastric bypass or some form of banding or vertical banded gastroplasty back in the 1980s and 90s. They had a control group where these individuals were being treated in their primary care doctor's office, similar weights as the surgical groups, though. What you see is the proportion of patients reporting medium risk alcohol consumption. Again, the numbers are more concerning for the gastric bypass patients, with the proportion of gastric bypass patients out to 10 years continuing to rise, actually, at that 10-year mark, and only a very small number, 1% or so, in the control group, whereas you've got 7% in the gastric bypass group. These other procedures that have been done, not so concerning for alcohol use as the gastric bypass. So again, Swedish obese subject study just confirming what we're concerned about in the United States, which is alcohol use in the gastric bypass patients. In terms of other addictive behaviors assessed by this structured clinical interview, there are a number of other addictive behaviors, including kleptomania, that's uncontrollable urges to steal things from shopping malls, pathological gambling, trichotillomania, impulse or compulsive buying, sexual behaviors that are impulsive or compulsive, internet use, and exercise dependence. I think the upshot here is that while there is a lifetime incidence of all of these things in bariatric patients, including buying and other addictive behaviors, really there are not many that are emerging post-operatively. You see the single digits here, suggesting to me that maybe there are individuals that did have a problem with these things. It doesn't look like this is mushrooming and becoming a much bigger problem post-operatively. In fact, it may just be declining post-operatively. What about teenagers? We actually have now published this data in SWORD just in the last few months. I'm sorry I don't have the citation down here, but it's Meg Zeller, Z-E-L-L-E-R, and the rest of us who authored this publication. We looked at the audit instrument administered to teens in the Teen Lab study, and also had a comparison group that Meg had recruited from all of our sites, the 5 sites of the Teen Labs study, numbering 79 in the control group. And it's important to have a control group for something like alcohol use, because these norms do change over time during development. So if you recruit someone at the age of 16 and 2 years later they're 18, they're much more likely to have undergone a developmental change because of their circumstances than in adults. So what we have here is the surgical group and the non-surgical group. 216 in the surgical. They underwent either gastric bypass or sleeve gastrectomy, most of them. Most were female. Most were Caucasian, with BMIs in the 53 range in the surgical and 47 in the non-surgical. That was different at P001. The surgical group lost 29% weight, and the non-surgical group gained 7% in weight, and this was certainly significant as well. This is over a 2-year period. So let's get to the audit data. What about alcohol? Most of them in both groups reported never using alcohol at baseline, 90%. This is actually less alcohol use than their peers who are not overweight when we look at the literature. So morbidly obese teenagers are less likely to be engaging in alcohol use than their non-obese peers that are the same age. However, 70% in each group reported never using alcohol even at 24 months follow-up. So still, very small numbers of them are using alcohol at 24 months, smaller numbers than their peer group at this ages that are represented by 2 years out from surgery. Now, in the surgical group, though, alcohol use over time, we found out, was related to BMI loss. So those who lost the most weight tended to have the most trouble with drinking, or I should say more commonly were the drinkers. About 70% increased risk of alcohol use for every 10-point BMI loss. Alcohol use in the surgicals is here in terms of these same 3 categories I told you about before: alcohol-related harm, dependent symptoms, or audit score greater than 8. Preoperatively, 4% went to 7%. This was not statistically significant. Dependent symptoms, 1.7% went to 4.4%. Again, not significant. And audit score greater than 8, 0.6 went to 1.7, not significant. In the non-surgical group, again, a lot of these did not change, at least not significantly. So I think that we can say that we are rest assured that the changes that we're seeing, the modest changes that we're seeing by 2 years, do not appear to be different or distinguishing these surgical patients as having something that is happening to them with regard to a alcohol issue related to surgery. They do not have any greater chances of an alcohol problem than the control group, which again is good news. We'll continue to follow them out. These patients are now on average about 4 years out, so there should be some interesting publications coming in the near future from that. One of the other interesting things to note here, and this has been reported as far back as 2002, is a dramatic increase in the absorption of alcohol after gastric bypass. We've seen it in a number of studies now, 5-fold increases in blood concentration of alcohol within 10 minutes, for instance. So that's a very meaningful difference, probably very clinically meaningful or socially meaningful when it comes to how quickly these individuals can get incapacitated or intoxicated. So even in sleeve gastrectomy, it was recently, in 2010, reported, again, a big difference here between before sleeve gastrectomy and after sleeve gastrectomy for alcohol absorption into the bloodstream. So why might there be misuse? Well, it might just be more fun. They get that quick high from alcohol use, and so that may have an effect on repetitive use behaviors. You feel something different than before. There could be an alteration in the brain circuitry as well. The dopamine reward pathways have been implicated. There's also this notion that the stomach itself is an organ of first alcohol metabolism or elimination, and so this first pass phenomenon, if you take away the alcohol dehydrogenase mechanism to reduce this alcohol concentration by doing a bypass or a sleeve gastrectomy, it may lead to a more potent increase in absorption. And of course, there could be combinations of these factors that may lead to a misuse of alcohol. But the implications seem to be, as shown here, for the adults at least, misuse by history or a history of alcohol abuse that's in remission should not be a rule out for bariatric surgery, but you should consider these patients high risk. All bariatric candidates should carefully undergo education and inform them about the risks of unsafe drinking afterwards and how little it may take to be unsafe. All the patients should be seen in follow-up, and alcohol reminders about this risk should be provided with each visit. So now on to the second topic for this presentation, suicide after bariatric surgery. Here again is a topic that's quite provocative, although it's not very common, thank goodness. To get our arms around it, it's so rare. In fact, to get our arms around it, what we have seen people do is to go to these large databases. Ted Adams used a large database from the Division of Motor Vehicles in the state of Utah, and he pulled individuals that had undergone bariatric surgery, and some 9,000, and compared them to age and BMI matched non-operatively treated people based on driver's license records. He could tell the weights, and he could tell other demographic features. And what he was able to show is that bariatric surgery was really good for them. Much lower mortality and disease-specific mortality in the bariatric surgery group. But there was this concerning signal about suicidal risk and accidents in some of the bariatric surgical patients. There were about threefold increase in that prevalence, but it was not significant because the numbers were so low. 15 patients out of 9,000, 15 out of 9,000 in the surgical group had died of suicidal or accidental deaths that were assumed to be suicidal, whereas 5 out of 9,000 had died in the non-operative group. So again, drawing a concerning signal, but not really big numbers here after 7 years after gastric bypass. In another state database study, we find residents of Pennsylvania 1995 to 2004. What these investigators found is that the rate of suicide after bariatric surgery was almost 14 per 10,000 person years after bariatric surgery. The U.S. norms were at the time 2.4 per 10,000. So this is a significant elevation over the expected U.S. norms. In females, again, 5.2 per 10,000 with a norm of 0.7 per 10,000. So suicide after bariatric surgery seems to be more common than one would expect after, or more common than one would expect compared to base rates in the population. The timing of the suicide seems to be between years 2 and 3. At least that's a spike in the timing. Some are seen in the first year and between the first and second year. The most common between the second and third year. Very little is known about suicidal ideation in teens. We are collecting this type of data in the Teen Lab study. It comes from the Beck Depression Inventory, but as of yet we've not analyzed these data and look forward to doing that in the near future. The only manuscript that I can see in the literature is from a lap banding program that Jeff Zeitzman runs in New York at Columbia University. And what his colleagues did is looked at suicidal ideation by reviewing the charts and found that 15% presenting to surgery have a history of suicidal ideation or suicidal behaviors. They ask the question, what happens to them over time after gastric banding? And it seems like at baseline they have greater depressive symptoms and a lower quality of life, as you might expect for those who have a history of suicidal ideation and behavior. The depressive symptoms in those in that group of suicidal ideation and behavior, a history of rather, the depressive symptoms fall and plateau after 3 months. Similarly, in those with a psychiatric history but not suicidal, their depressive symptoms fall and plateau after 3 months, but they plateau at a much lower risk level. So I'd have to say that because of the persistent difference between depressive symptoms in these groups, perhaps this group is at higher risk for problems in the future. I think that time will tell. This is only a 12-month study. In this same study, though, they demonstrated that there was no detectable effect of the history of suicidal ideation and behavior on BMI change. Now here, again, we see this very modest BMI change that we've come to expect after gastric banding, going from about 47 BMI to about 40 BMI. So probably better than dieting and lifestyle, but not like the differences that we see in BMI change after gastric bypass or sleeve gastrectomy. So in conclusion, increased risk of alcohol problems have been noticed after gastric bypass, and they're probably similar after vertical sleeve gastrectomy from a few studies that have been done. There seems to be no particular increased risk of alcohol problems after gastric banding, though, in adults. In teenagers, the emergence of drinking behaviors at 2 years seems to be developmentally appropriate. It's not necessarily associated with the surgery, but seems to just be one of those consequences of growing up and becoming a young adult. The alcohol absorption, though, after gastric bypass and vertical sleeve gastrectomy is worthy of mention, and it's worthy of really specific guidance to the patients beforehand and at their follow-up visits, because they can really get into trouble if they don't understand how quickly they can become intoxicated and get into a motor vehicle accident or other trouble. So harm is possible with less intake, and that's the message that we provide to our patients. In terms of other addictive behaviors or this notion of addiction transfer, we really don't know enough about that. We don't have solid data on bariatric surgery leading to a unforeseen increase in other addictive behaviors. I think that that this is an area that we really have to keep a close eye on, though, and in particular, addictive behaviors, risk-taking behaviors, major areas for continued and future research. Suicidal behaviors appear to be more common after bariatric surgery in adults, and I think from the emerging adult literature, we can make some initial speculations about the teenagers. Right now, there is insufficient data in the teenagers to draw any conclusions, but I do think that that from the adult literature and understanding that it's depressive symptoms that are more commonly seen in these individuals who have suicidal risk, we really want to keep a close eye on depression and realize that they are at risk if it recurs. They're also going to be at risk potentially if there is dissatisfaction with the outcome of their surgery, particularly if they haven't lost weight or if they've regained all their weight. Sometimes these patients consider this the very last option that they have for weight loss, and if they're not successful, it can be quite demoralizing. and hopelessness can easily set in and put them at risk for self-harm. So I think that we've got a lot of data that will be coming out soon, within the next few years on this topic. We certainly are concerned, and we'll look forward to analyzing that and sharing it and looking at other data from around the world as well. So with that, I'll thank you again for the opportunity to give this screencast. From Cincinnati, this is Tom Inge signing out. Have a great rest of your meeting there in Chihuahua. I'll see you later. Bye-bye.